So, a very good evening to all of you. Welcome to the clinical case discussion. I hope you are well and enjoying this clinical case discussion with me. Before starting with today's clinical case discussion, just I want a confirmation. Is my audio video clear, guys? Somebody can comment in the live chat. Is my audio video clear to you? Because I'm going to show you something. That is why it's very important that my audio and video should be clear. We'll do something interesting today. So tell me if my audio and video is clear. Somebody can comment in the live chat if my audio video is clear. Anybody? What I'm going to do today, I'm going to show you a video, and you people have to tell me what is that, where do you do it, and then we are going to discuss it. Because nowadays we will be doing the MCQs in a fun learning manner, and studies will always be easy when we are doing it in an interesting manner. So I tried to do something interesting today. It's totally fine. Okay, I think I'm getting the messages now. There is some lag of issue. Yes, so thank you so much, all of you who have told me. Thank you so much. Alright, so what I'm going to do, I'm going to play a video and you have to tell me what it is, okay? Look at the video very carefully, what is being done, and then we are going to discuss it. Look at this men and what we are going to do it. Please see. What is this? Yes, ma'am. Okay. So if it is fine, please can you please tell me what it is? I am going to play it once more. I am going to play it once more, guys. Please see what is being done. Look at this men and what is being done. Something is done and then they are seeing. I don't want the diagnosis. I want the name of this test. What is being done? What is being done, guys, here? Then I'll come to the point where it is done. But right now I'm asking what it is. So some people have answered that where do you do it? But actually I want what is this? Please watch it carefully what we are doing here. Please watch it carefully what we are doing and what... Kanchan, it's not this. Kanchan, please see carefully what is being done. See, we are doing cover uncover test. We are doing with the help of your occluder. This is not a occluder. Cold fermentation. No, it's not cold fermentation. I can see some of the right answers also. So see here now. Now I will tell you how to look at this video. Can you see there is a ptosis in this eye? There is a ptosis in this eye. And now what we are putting is a ice pack. Good evening. And then 5 minutes later we are putting out the ice pack. And then you have seen that it is improving. The ptosis has improved. Yes, ptosis recovery. So after what the ptosis is recovering? After removing this ice pack, the ptosis is actually improving. So what is the name of this test, guys? Now tell me, what is the name of this test? Can you tell me what is the name of this test now? Yes, so Avinash is also there. Yes, very good Aman, very good Shyam, Shri Jewels. Okay, so this is actually the ice peck test. This is actually the ice peck test. So where do you do this ice peck test actually? Where do we do this eye spec test? This is again a very important topic where you get a lot of integrated questions. That is why I have tried to take this topic today with the help of a video, and 2 to 3 years back there were about 3 videos which they give in the AIIMS. So looking at the current scenario where they are asking new kind of things, interesting kind of things, I think this is not a bad deal. You should know about this eye spec test. This eye spec test, which is done where? In ptosis. Which ptosis you are doing? So another important question is, where do you do this eye spec test? Eye spec test. Where do you do this eye spec test? Another important question, because if they are showing you this video, maybe they are asking you the name of the test, then they can also ask you where do you do it. And once you know where we do it, then we will be discussing the other important aspects. Exactly. So we are doing this eye spec test in the myasthenia gravis. Okay. Now, other way around, the question can be asked, what is the most important ocular manifestation of myasthenia gravis? Can you listen to this question? What is the most important ocular manifestation? What is the most important ocular manifestation of the myasthenia gravis, right? So can you give me this answer, because the rest of the discussion will depend upon this answer only. Yes, exactly. So the most important ocular manifestation of this myasthenia gravis is actually ptosis, right? Now, once we have reached to this diagnosis, what are the important features which are very, very unique to the ptosis of the ocular myasthenia gravis? When I am talking about the ocular myasthenia gravis, when I am talking about the ptosis which are found in the myasthenia gravis, there are 3 important things. If you read any of these 3 things in the question, we can get a clue that this is related to myasthenia gravis. See, I am not teaching something new, but I am trying to help you how to correlate the things and how to actually approach the clinical case scenarios. Once the diagnosis is clear, solving the question is not a problem. If you know the diagnosis, you can easily tell the test, the next step, the best step, the treatment and everything. So the important thing is you should know the catch points for the diagnosis. So can you help me this? What are the 3 things that you should see? Yes, so there are so many. Very good, very good. There are so many right answers. Ptosis is the most common ocular manifestation of the myasthenia gravis. Now, what are the things that you have to look? I have already told you that you have to look for 3 things in the ptosis for the myasthenia gravis. If the patient is having ptosis with the myasthenia gravis, what are the 3 things? First of all, it worsens with the day. So, number 1 is the variability. Number 1 is the variability, means it can be variable during the day. It can be more, it can be less. So this is the first thing. Variability is an important thing. It is variable. What is the second important thing? Very good, Soumya. What is the second important thing? Asymmetric. Number 2 is the asymmetric. Means the amount of ptosis can be different in one eye, it can be different in another eye. And what is the third thing? Third thing is easy fatigability. easy fatigability. Please note down these three things. If you are getting these three things, one thing I want to remind you, I told you in the previous class also, please make a notebook of these clinical case scenarios, because you know they are very good questions that I am trying to put in front of you. And one thing I can assure, see, exact language of the question cannot be promised, but I definitely can say that all these are very high yield topics, and definitely the most expected topics in your upcoming exam. Both of your major exams, the INI CET as well as NEET is coming up, and I want you, all of you, to take hold of these questions, note down these topics and all those points that I am telling you, because they are going to help you. So if you keep on noting down them, it will be easier for you at the last minute to revise these things. Okay. If you want the video, then I'll be sharing this video on the group. That is not a problem. Yes, very good, Aman. So asymmetry, variable visualization, variability. It is called as variability. Asymmetric is there, variability is there, and easy fatigability. Okay. Now, where do we have the pathology? Where do we have the pathology in cases of myasthenia gravis? So it is actually a problem at the level of neuromuscular junction. This is the problem at the level of neuromuscular junction. So what will happen to the pupil? Another important question. These are the small things which they are going to ask, basic. Okay, see, there is a lot of difference between the pattern of the INI CET and the pattern of NEET. The topics will be same, but their way of asking the question varies a lot. है ना? The NEET people will focus more on the clinical subjects, medicine, surgery, gynae, ophtha, ENT, PSM. But the INI CET people will ask you more towards the basics. So there is actually a difference, and because we tend to read the hi-fi things and clinical things more, so that is why sometimes we may feel that INI CET paper is difficult. It is not difficult because they are asking very high yield concepts, very difficult concepts. The thing is that they are asking very basic things, and because when we are preparing so much for the entrance examination, we tend to lose our grip over the basic things. That is why I'm trying to focus on the basic things. So this is actually a problem of neuromuscular junction. Hi Satvik. Yes. So basically what will happen to the pupil if it is a problem of the neuromuscular junction? What will happen to the pupil? Are you going to get pupillary abnormalities? Now why we are worried about pupillary abnormalities? Because basically we are talking about ptosis. The most common ocular manifestation is ptosis. Now can you tell me what is the most common cause of ptosis? What is the most common cause? Most common cause. Who will tell me the most common cause of ptosis? Ptosis means what? Drooping of the upper eyelid. So what muscle is the elevator of the upper eyelid? Elevator is the levator palpebrae superioris. Levator palpebrae superioris LPS muscle. What is the nerve supply? Now see another important question. The nerve supply is all are supplied by third except SO4 and LR6. Another important mnemonic. The mnemonic is all three SO4 and LR6. All are supplied by the third cranial nerve except the superior oblique, which is supplied by fourth cranial nerve. Lateral rectus is supplied by the sixth cranial nerve, right? So that means LPS is supplied by the third cranial nerve. So what is the most common cause of ptosis? Another important question. Yes, Geetika is correct. The most common cause is not, I am not talking about the senile causes actually this time. I am talking about the acquired causes. So out of the acquired causes, what is the most common cause? That I can agree, amongst all the causes, senile can be the most common cause. But amongst the acquired causes, the most common cause will be your third nerve palsy. Okay? Now when I am talking about the third nerve palsy, what are the features of third nerve palsy? Now if I talk about the third nerve palsy, because it is supplying all the extraocular muscles except the superior oblique and lateral rectus, so that means only two actions can be done, the actions which are done by superior oblique and the actions which are done by lateral rectus. Now who will tell me the actions of superior oblique? Come on. Actions of superior oblique and actions of lateral rectus. Now always remember, rectus means what? Rectus means straight. ठीक है? Rectus means straight. So rectus muscles will always take the eye to the straight and same. S for straight and S for same. So these muscles will move straight in the same direction. Superior rectus superiorly, inferior rectus inferiorly, medial rectus medially, lateral rectus laterally. ठीक है? Superior rectus superiorly, inferior rectus inferiorly, medial rectus medially, lateral rectus laterally. Easy है? तो lateral rectus, what is the important action? Abduction. Straight laterally. So this will do the abduction. The abduction. And then we have the superior oblique. Superior oblique के actions क्या हैं? For the superior oblique actions, again I will tell you, you don't have to cram it. Okay, there is very easy thing. It's very easy how to do it. Yes, abduction हो गया lateral rectus का. ठीक है? Now, what are the actions of superior oblique? Now, this is again an important task, how to divide the actions between the rectus and oblique. तो इसको करते करते हम ये भी करेंगे how to do it. So, we have certain steps. Okay, we have got certain steps for doing it. Number one step is whether it's a oblique versus whether it is a rectus. Whether it's a oblique muscle or it's a rectus muscle. Now, if it is a oblique muscle, what will be the main action? It is intorsion or extorsion. And if it is a rectus muscle, main action will be your elevation or depression. So because you so many times get a question regarding the actions of the extraocular muscles, and it is very important how to do it. So oblique, ठीक है? Oblique will do the primary action as intorsion, extorsion. If it is a rectus muscle, primary action is elevation, depression. Now mine is oblique, so that means either it will do intorsion or extorsion. ठीक है? Now the step number 2, if it is intorsion, extorsion, superiors are in tortus. Superiors are in tortus. So this is my superior oblique. Therefore, my primary action will be intorsion. So primary action will be your intorsion. Now, if I go to the secondary action, ठीक है? Now, because primary action is intorsion, extorsion, so secondary action क्या हो जाएगा? Either elevation or depression. ठीक है? Now, O for oblique and O for opposite. This is a very important, trick for doing this question. O for oblique, O for opposite. So it says a superior oblique, therefore it will cause depression. ठीक है? So secondary action is depression. And how to decide for tertiary action? Tertiary action may always remember the RAD. ठीक है? It's a RAD. RAD means recti are adductors. Recti are adductors. ठीक है? Therefore, oblique कैसा हो जाएगा? Therefore, obliques will cause abduction. So, if I am talking about superior oblique, so its tertiary action will be abduction. तो ये आ गया हमारा टर्शरी एक्शन. फर्स्ट ऑफ ऑल टेल मी, हैव यू गॉट दिस, हाउ टू कैरी आउट द एक्शंस ऑफ द एक्स्ट्राओक्युलर मसल्स? वेरी गुड, है ना? Because if you understand this, you will get to solve so many questions. Now that means if I am talking about superior oblique and lateral rectus, ठीक है, तो what are the actions which are possible here? Superior oblique का इंटॉर्जन, second was your depression, है ना, and depression in the adducted eye, while tertiary action is abduction. Now next time we will be talking about the Park 3 step test, because there is always a confusion in you that depression of the adducted eye while the tertiary action is abduction. So I am not going towards that direction today. Lateral rectus का abduction, ठीक है. Now because only these two muscles are working, therefore what will be the position of the eye? How will be the deviation of the eye, guys? The deviation of the eye will be depression and abduction. So this will be down and this will be out, down and out, ठीक है ना. तो eye will be down and out, plus you will have ptosis, plus what will happen to the pupil? Pupil is dilated. Now because in cases of the third nerve palsy, pupil is dilated, whenever we have ptosis, I have to look at the pupil. Though we have something which is called as pupillary sparing third nerve palsy. Though we have something which is called as pupillary sparing third nerve palsy. Now who will tell me the causes of pupillary sparing? We have solved at least 10 to 15 questions till now in one question. So yes, exactly, ठीक है. So what is pupillary sparing third nerve palsy? Pupillary sparing third nerve palsy is found in the medical disorders. In the medical diseases, like we have diabetes and the hypertension. Like we have the diabetes and hypertension. Pupillary sparing third nerve palsy is found in the diabetes as well as hypertension. Okay, that is why it is important. Superior oblique palsy will cause what? Superior oblique palsy will cause up and in. Okay, Avinash. So medical disorders are causing pupillary sparing third nerve palsy. So what will happen to the pupil in cases of myasthenia gravis? Now another important question. Who will answer this? What will happen to the pupil in cases of the myasthenia gravis? Because it's a problem of neuromuscular junction. Therefore the pupil will be normal. Another important thing, pupil will be normal. Now can you tell me what is the first muscle which is affected in myasthenia gravis? We have already done this. Pupil will be normal. Then second important thing, neuromuscular junction. Then variability, asymmetric, easy fatigability. This is also done. Then what is the first muscle to be affected in myasthenia gravis? Yes, anybody who can answer this? What is the first muscle? Pupil will be normal. What will be the first muscle which is affected? First extraocular muscle which will be affected in cases of myasthenia gravis. Another important question. No, it's not LPS muscle. LPS muscle is not the first muscle to be affected in myasthenia gravis. Any other answer? No, LPS is not there. What is the first muscle? Always remember M for M. M for M. Myasthenia gravis में it is the medial rectus. Remember M for M. So this is again a mantra for you. This is a mantra for you. M for M याद रखना है. Myasthenia gravis में the first muscle which is affected is the medial rectus. Okay. Now let us do one question related to it. See this. Now tell me the diagnosis here. A ptosis patient complains that eyelid drooping varies with a day. ठीक है? He is also having restriction in the mobility of his eyes. What is not true for the condition? Yes. भूल गए थे ना अविनाश? So that is why, time to time revision is important. Now again a mantra for you. M for myasthenia gravis and M for medial rectus. Yes. It was inferior rectus for the thyroid eye disease and it is the medial rectus for the myasthenia gravis. So what is not true? Now who will tell me the answer here? Two things we have already done. It improves with putting the ice pack over the eyes. This is true. We have already seen. Number 2, pupils are unaffected. This is also true. So we have done already. So this. Then number 3 also we have done. Medial rectus is the first muscle to be involved. So by the diagnosis of exclusion, this becomes your answer. Now, even if you do not know, see, every time I teach you, I always say that it is best to solve the MCQ by the diagnosis of exclusion. Eye peak sign is due to the levator muscle. Now, even if you do not know what is this eye peak sign, you do not know whether it is due to the LPS muscle or not, but if you have done the other 3 options and you know that they are true, so only false statement will be this one. So though I will tell you what is this, but are you seeing the magic of diagnosis of exclusion? Hello everyone. तो आई पीक साइन क्या है वो देखते हैं. See this. Oh, just a second. Now see this. This is actually, can you see the third picture here? This is your eye peak sign. Now what happens? The myasthenia gravis actually involves the skeletal muscles. Okay? It involves all the skeletal muscles and the extraocular muscles are your skeletal muscles. So basically we have the antibodies formed against the acetylcholine receptors and that is why we have a problem with the skeletal muscles and that involves your extraocular muscles. Now eye में one more muscles are there. We have LPS, we have 4 rectors, we have 2 oblique, we also have a orbicularis oculi muscle. Who will tell me the nerve supply of orbicularis oculi, guys? Nerve supply of the orbicularis oculi. The nerve supply of orbicularis oculi is actually your facial nerve. Okay? Now, what happens? What is the function of this muscle? Closure of the eyelids. The function of this muscle is closure. Now, whichever eye, is having the myasthenia, we will have the fatigability. So suppose I ask the patient to close the eyes. So he will use which muscle? He will use orbicularis oculi muscle. Yes, close the eyes. But because this muscle is actually weak, there is fatigability. So slowly, these eyes will start opening up. So there is peaking of the eyes through the lids. So they will start opening up like this. This is called as eye peak sign, which is due to orbicularis oculi muscle and not the LPS muscle. Now, who will tell me which sign is due to the LPS muscle? Which sign is due to the LPS muscle? They are saying the eye peak sign is due to the LPS muscle, which is wrong. That is due to orbicularis oculi. Now, can you tell me the name of the sign which is due to this LPS muscle? What is the name of that sign? No, ptosis के बारे में नहीं मैं बात करी. Like this is your eye peak sign. This is called as the eye peak sign. Similarly, we have got one more sign. That one more sign is due to the LPS muscle. So, which sign is actually due to the LPS muscle? That sign is called as the Cogan's lid twitch sign. Cogan's lid twitch sign. It is this Cogan's lid twitch sign which is due to the LPS muscle. Now let us see what is this lid twitch sign. Now suppose these are the two eyes. One eye is having the myasthenia gravis, one is normal. Okay? Now I ask the patient to look in the primary position like this. Then I ask the patient to look in the downward gaze. And then patient has to look up. Now normal eye will sustain, but the myasthenia gravis eye will not sustain because there is easy fatigability. So the moment this eye will come up, it will quickly come down. The moment this eye come up, quickly come down. So this eye quickly coming down, this is actually called as the lid twitch sign. This is quickly coming down is called as lid twitch sign. So this was your ocular myasthenia gravis with ptosis, the most important sign, the important characteristics of this ptosis, the important sign. What are the differences between the third nerve palsy and the ocular myasthenia gravis ptosis? Is it very, very clear, guys? Everyone? Now I am going to show you another important thing. You have to tell me what is this, okay? Look at this. What is this going on? What can you see here? What is the stain used? Which filter is being used here? See, what are the questions I am asking? What is being done here? What is the stain used? What is the filter that is being used here, guys? So, see this again. Repeat telecast for you. What is this? See this. Jaldi jaldi comment. Quickly see. Let me see what are the who are the people who are answering fastest here. This is not EOG. फिर से देखो. What is being done here? Yes. What is see again I am showing you third time. ठीक है? Please give your answers quickly. What is this test? What is the stain which is used and what is the filter name? Filter. Can I get some more answers here? Stain Avinash. Which stain we are using here? Now see again. Now I am showing you how to look at it. You can see the two Meyers which are forming. These are the two Meyers. This is one Meyer, the semicircle. This is another Meyer, the semicircle. And the colors are green. The green colors. Okay? So the blue is your cobalt blue filter. Cobalt blue filter stain is the fluorescein stain. And what is the name of this test? It is the Goldman's applanation tonometer. Please see it again. I want everybody to see this because this is really, really important. This has come in the AIMS examination 2017 as the image-based question. As the image-based question, please look at it. This was an image-based question in AIMS 2017. Goldman's applanation tonometry. Green color Myers with the cobalt blue filter. ठीक है? So let us discuss some things about this. I wanted to discuss a question related to this. Okay, now let us read this question and then we will be discussing. We have a 62-year-old man. Okay. So we have a 62-year-old man who is coming to a physician. Look at the age of a patient. Look at the gender of the patient. Coming to the physician because he is having sudden onset of pain and redness. He is having sudden onset of pain and redness. He is also having photophobia, nausea, headache. That is not responding to ibuprofen. We have sudden onset of pain. Redness is there. Then there is no trauma. And he has never had such an episode before also. Okay? On the review of systems, the patient has a mild cold. He was having a mild cold for which he had used over-the-counter oral decongestants. Physical examination shows a pupil which is fixed. Non-reactive pupil we have. Mid-dilated. Non-reactive mid-dilated pupil with conjunctival flushing. What is the best next step in evaluating the patient's condition? Now, before telling you the answer, I must tell you one thing. Whenever they are saying next best or best next, then they are actually asking only next, because whenever they are asking like this, you got confused and you tell us the best thing. You don't have to tell the best. They are telling the next best. So basically they are asking the next test, not the best test. They are asking the next test, not the best test. Anybody who can tell me the diagnosis of this patient, I am not asking what is the next test that you are going to do. Anybody who can tell me the diagnosis now, I have told you about these similar kind of questions so many times. This patient is having sudden onset of pain and redness. So this is sudden painful diminution of vision. Now, whenever I am having sudden painful diminution of vision, we can have two things: acute congestive glaucoma or acute anterior uveitis. Okay, these are the two main DDs. Now, what are the other things that this patient can have? 1 and 2 is this. 3, we can have acute bacterial keratitis. We can have acute bacterial keratitis. Number 4, we can also have the chemical burns or chemical injuries in the eye can also lead to the sudden painful diminution of vision. We can have acute congestive glaucoma, acute anterior uveitis. We can have acute bacterial keratitis. We can have the chemical injuries. So out of the these 3-4 things, what do you think is the most important investigation? Wow. Yes, so Avinash has told even the rarest one. Okay. So yes, so this is a patient of acute congestive glaucoma. Now another important question, why this patient is having acute congestive glaucoma? Because otherwise acute congestive glaucoma is common in females. It is more common in after 50 years of age, and it is more common in the females. Okay? But here we have a male, we have got 62 years, but he is having the symptoms of acute painful diminution of vision, photophobia, nausea, headache, everything we are having. We are also having cold. कोल्ड के लिए the person is using the oral decongestants, and oral decongestants has led to precipitation of the attack of acute congestive glaucoma. Yes, so why oral decongestants have precipitated the attack of acute congestive glaucoma? Because they can actually narrow down the angle of anterior chamber. Any antipsychotic, can you name any antipsychotic which can precipitate the attack of acute congestive glaucoma? A similar kind of a question came in INI-CT, I think November. INI-CT November में and I had discussed a similar kind of question in the clinical scenarios also. There is a certain group of drugs in the antipsychotics which can precipitate the attack of acute congestive glaucoma, and actually they should not be given in the people having the narrow angle of anterior chamber. Any of the answers? Any answer in that respect we can have? Anybody? Any antipsychotic which can precipitate the attack of acute congestive glaucoma? It is actually amitriptyline. Amitriptyline, the tricyclic antidepressant. Very, very important NEET question. Oh, sorry, INI-CT. INI-CT question 2021. 2021. It is amitriptyline. ठीक है? So, if I am already sure that this is a patient having the acute congestive glaucoma, what should be the next step that I should be doing? CT scan of the head, duplex studies of the carotid artery, fluorescein staining of the eye, lumbar puncture or tonometry. Yes, तो antidepressant भी अच्छा, to be very precise, yes, it's an antidepressant. ठीक है, मेरे हिसाब से एंटी डिप्रेसेंट एंटीसाइकोटिक्स में ही आती थी. ओके, यस, विच एंटी डिप्रेसेंट? INI-CT people ask about the what, which antidepressant actually causes the precipitation. So I am correcting myself. Okay, तो ये बताओ which is the next test that you should do in this condition? Next step, should you do the CT scan, duplex studies, fluorescein staining of the eye, lumbar puncture or tonometry? What you are going to do? अच्छा ये बताओ, where do you do the fluorescein staining of the eye? What scenario? Whenever we have got some corneal abrasion या corneal erosion. It can be a corneal ulcer, we can have recurrent corneal erosion. Then in those kind of condition, we can have any foreign body also. We can have the corneal foreign body. So whenever we have such type of things where you are suspecting some injury to the corneal epithelium, there we are doing the fluorescein staining. Okay. Okay. Second, where do you do this duplex studies of the carotid artery? Where do you do the carotid Doppler? Where do you do the carotid Doppler? The duplex studies of the carotid artery or the carotid Doppler. Another important question. Because if you know that where should you do the carotid Doppler, where should you do the fluorescein staining, where do you do the lumbar puncture, then this answer will become very, very easy. Where do you do the carotid Doppler? In the cases of ocular ischemic syndrome, in the cases of the ocular ischemic syndrome, we are doing the duplex studies of the carotid artery. Now, there is a difference between the best test and the next test. What is the first test that you do in ocular ischemic syndrome? In the ocular ischemic syndrome, what is the first step that we are going to do? Then, what is the next step that you are going to do? Then what is the investigation of the choice that you are going to do? And then what is the best test that you are going to do? Another important thing. So whenever we are having a patient of ocular ischemic syndrome, we will have the carotid stenosis. We will have the carotid stenosis. more than 90%. We will have the carotid stenosis more than 90%. Then we are suspecting this ocular ischemic syndrome. Okay. So the first step that we are doing is what? Have you answered it? Please answer करो. मैं तो सब बता ही दूंगी. So what is the first step? If I am suspecting, what is the most common cause of carotid stenosis, ocular ischemic syndrome? We will have the transient ischemic attacks. We can have the giant cell arteritis, CRAO. Then we can have the asymmetrical diabetic retinopathy. Transient ischemic attacks can be there. We can have giant cell arteritis. We can have CRAO. We can have asymmetrical diabetic retinopathy. Now this is again very important. One of the presentations of ocular ischemic syndrome. Indirect ophthalmoscopy क्यों करेंगे बेटा? Why we are going to do indirect ophthalmoscopy? अब क्या होता है? Suppose you will give this answer to me in the Viva, then I will ask you, what is the use of indirect ophthalmoscopy? So indirect ophthalmoscopy is used to see the periphery of the retina. So am I interested in seeing the periphery of the retina here? दूसरा बोल दिया CT angiography. CT angiography. Why I am doing the CT angiography? No. Whenever we are suspecting this giant cell arteritis as a cause of this ocular ischemic syndrome, ठीक है? The first step that we are doing in giant cell arteritis is your ESR. This is the first step that we are going to do. Now once we have got the clinical features of the giant cell arteritis, who will tell me the features of giant cell arteritis? We can have the scalp tenderness. Scalp tenderness is there, and then a very important thing is the jaw claudication. Then we also have the jaw claudication. We can have the scalp tenderness. We will have the jaw claudication. Here you will have the weakness in the masseter muscle. Due to the weakness in the masseter muscle, we will have jaw claudication. The first thing that I am going to do is the ESR. Now once we are getting this raised ESR, then the next step is start the steroids. This flowchart will again help you like anything in solving the MCQs. If they are asking the first step, then it is the ESR. Then if they are asking the next step, in the next step, you have to start the steroids. Then what is the investigation of choice? That will be your Doppler, carotid Doppler. That will be the carotid Doppler. And what is the best test? अब ये तो बताओ, what is the best test for giant cell arteritis? Retinal morphology. Ganesh is a very broad term, है ना? Retinal morphology नहीं, periphery of the retina. Central retina is seen by which instrument? Scalp tenderness होगा, very good Chinmay. Jaw pain होगा. Why we are getting the pain in the jaw? Because of the ischemia of the masseter muscle. Which muscle? Masseter muscle. So you can get a clinical anatomy question. Which muscle is affected? Masseter muscle. Temporal artery. Yes. So best test is the biopsy. It is the biopsy of the temporal artery. We are going to do the biopsy of the temporal artery. So we are doing so many tests. The first test is your ESR. Next is we start the steroids. Investigation of choice is your carotid Doppler. And the best test is the biopsy. Biopsy of the temporal artery. That is the best test that we are going to do. So what will be the answer here then? Where do you do the lumbar puncture? And where do you do the CT scan of the head? ये भी बहुत बार आता है whenever you have questions related to radio also. Direct ophthalmoscopy is used to see the central retina. Exactly. Direct one is used to see the central retina. So CT scan. Where do you do the CT scan? Usually we are doing it in cases of the trauma. Usually we are doing it in cases of the trauma. The CT scan of the head, whenever we are having the trauma, like we can have the subdural hemorrhage or we can have the extradural hematomas. subdural hematomas, extradural hemorrhage. In all these cases, we are doing the CT scan. We can see the collection of the blood and all. Or we can do the in cases of calcification. In the cases of the calcification, for example, we can have the retinoblastoma. In order to see the calcification, but usually we do not do this in cases of children because there is a risk of radiation exposure. That is why we are not doing CT scan. What is the investigation of choice for retinoblastoma, guys? Investigation of choice for the retinoblastoma. Everything is important about retinoblastoma. Lot of questions in NEET 2021 also about the spread, about the investigation of choice, Flexner, Winter, Steiner, Rosette. So what is the investigation of choice for retinoblastoma, guys? Any answer for that? Investigation of choice for the retinoblastoma, your options are B scan. नंबर 1 इज बी स्कैन. ERG तो करते ही नहीं है. बी स्कैन, CT स्कैन, देन MRI और दी indirect ophthalmoscopy. What is the answer? What is the investigation of choice for retinoblastoma? आई हर्ड समवेयर. समवेयर बहुत ही वेग टर्म होता है. समवेयर कुछ भी नहीं होता बेटा. ERG फॉर द रेटिनाइटिस पिगमेंटोसा. एग्जैक्टली. लेकिन आई एम आस्किंग यू अबाउट रेटिनोब्लास्टोमा, नॉट द रेटिनाइटिस पिगमेंटोसा. व्हाट इज द इन्वेस्टिगेशन ऑफ चॉइस फॉर रेटिनोब्लास्टोमा? Exactly, it is the MRI. MRI orbit is the investigation of choice for the retinoblastoma. We start with the ophthalmoscopy. We do the B scan also. CT scan is good because we can see the calcification, but usually we are avoiding because of radiation exposure in children. Because of the radiation exposure in children, we are actually avoiding it. So investigation of choice is actually the MRI orbit. ठीक है, तो ये हो गया. Where will you do the lumbar puncture? In cases of ophthalmology, any condition where you would like to do the lumbar puncture? Where will you do the lumbar puncture actually? Pedia people are calling us so many times for looking at something before they are doing the lumbar puncture. So whenever we have got the raised intracranial pressure, okay, so we are doing this. So because you know this patient is having the acute congestive glaucoma, which of the following is the next step in evaluating this patient's condition? It will be the tonometry. Now coming to the question, what tonometer we had shown. See, when I am talking about the tonometer, whenever I am talking about the tonometer, you have to remember two things: the most common and the gold standard. And the gold standard. The most common tonometer is the Schiot's indentation. Schiot's indentation tonometer. Schiot's indentation tonometer. While the gold standard is the Goldman's applanation tonometer. So what is the difference between the two? This is a indentation tonometer, while this is a applanation. This is a applanation tonometer. Indentation tonometer and a applanation tonometer, where you are using the fluorescein stain. The another important question that I asked, the name of the tonometer was Goldman's applanation tonometer, and the stain is fluorescein stain. Name of the filter is the cobalt blue filter. The name of this filter is the cobalt blue filter. Goldman's applanation tonometer, fluorescein stain, cobalt blue filter. and the principle that we are using is the Imbert-Fick law. Imbert-Fick law, which says that pressure is equal to force upon the area. Pressure is equal to force upon area. So P is equal to F upon A. ठीक है. Force which is required to applanate, मतलब flattening. Force required for the flattening of the cornea. Force required for the flattening of the cornea divided upon the area of the cornea. Flattening of the cornea divided upon the area of the cornea. Now, area of the cornea is actually fixed. 3.06 mm. Diameter of the cornea. This is 3.06 mm. So, because this is fixed, therefore it is also called as fixed area tonometer. So, this is also called as the fixed area tonometer. So, I can say pressure is directly proportional to the force because area is fixed. Therefore, pressure is equal to F into constant. And what is this constant? This is equal to F into 10. So, whatever reading you are getting the Myers now. So, you will have the Myers like this. So, whenever these Myers are touching the inner ends like this. Like if they are like this, it is wrong. If they are overlapping each other, it is wrong. This is right. So, whenever we are getting this, these are called as Myers. Take the reading. This reading will give you the force multiplied by 10. This will give me the intraocular pressure. So, this is the concept behind the Goldman's applanation tonometer. Hello everyone. Now, before leaving the session, I will show you one more thing, and that we will be discussing on next turn. So, that is a question for all of you. What is this and what it is used for? What is this instrument? We will be discussing this on the next turn. Same day, same time. What is this? See again. I'll play again. What is this instrument and what it is used for, guys? See, ध्यान से देखना. What is this instrument and what it is used for? Anybody having any ideas can give me the answer. Discussion will be done on the next turn. And one more time. See this. What is this instrument and what it is used for? So this is all for today, guys. I hope you like the session. Please give me a feedback that is most required about these clinical case scenarios, because I am trying to bring something new, something interesting and something very high yielding for the upcoming sessions also, so that the INICET and the NEET are going to be very, very nice experience for you, and you all will be coming in the flying colors. So stay blessed and keep on studying. Happy ophthalmology. Goodbye.